Thanks everyone for coming out to spend time with us tonight. So again, I'm Mike Gilbert. I've been with Monadnock on and off for about 11 years, usually as a satellite of some of the bigger systems in the state, Dartmouth and CMC. And about a year ago, with a lot of the shifting changes in the landscape of healthcare, the administration asked me to come here full time. And so it's been my privilege to be a part of the Monadnock team full time for the past year now. It's an amazing community, and we're doing a lot of good here. And since I've been here, I developed a goal. So it's a big goal, but my goal is that no one that is served by the Monadnock Hospital catchment area should ever die of colon cancer. And it's a big goal, but I think with the team that we have put together, we can achieve that over time. So I'm going to talk to you a little bit tonight about colon cancer. I'm going to talk about screening for colon cancer, why it's important to get screened, a lot of different modalities. Some I do, some your primary team can do. And then we're going to talk about some of the problems that can occur if we don't get screening. This is not a lecture, it's a conversation, okay? So anyone has a question anytime, just shout it out. I can guarantee you that if you have a question, somebody next to you does as well. And it's very important because the worst thing that people could do is ignore something and then have it turn into something that is really bad. So we'll get started. I think the best thing we should do, though, is start with the quiz, right? So we have prizes and a quiz. So first question on the quiz is, if you rank the different cancers, you can get cancer in almost any part of your body. Where does colon cancer rank? Is it like the most common? Is it the least common? Is it in the middle? And if you don't volunteer, I do have a laser and I'll call on people. In the middle. Anyone else?
Third.
Third. Who said third? All right, so you get a t-shirt. All right, so there's prizes. All right, oops, sorry. All right, so if you think about colon cancer, men and women get different cancers, but when you put them together, it's the third most common, okay? So men get prostate cancer, they get lung cancer, especially if they smoke, and then they get colon cancer. Women get breast cancer, again, lung cancer if they smoke, and then colon cancer. It actually turns out to be the second most common cause of cancer death in Americans when you group those two together, okay? All right, next quiz. All right, so if we think about like one in so many, how many people would get a polyp on their first colonoscopy? So like, is it 1 in 1,000, 1 in 100, 1 in 10? 1 in 100? Anyone else?
1 in 10.
1 in 10, anyone else? 1 in 1,000, okay. So it's actually 1 in 3. So if you think at all comers at 45 when screening starts, 1 in 3 of them will have a polyp. Okay, so no one gets a shirt on that. All right, so how many people get colon cancer? 1 in how many people will get colon cancer in their lifetime?
24.
1 in 24. Anyone else? 1 in 30. Okay. So it's 1 in 19 to 1 in 20. Okay, so that's a very common thing. So if you think about it, there's about 20 of us in here. One of us is going to get colon cancer, right? And if you think about it, pretty much one person in each row is going to have a polyp at some point. And that's just at age 45. As you age, that goes up. So like half of 80-year-olds should have a polyp. As we age, we get more and more risk of getting polyps. Yes, sir?
The definition of a polyp, does that mean that it's bad or just that it has a polyp that needs to be looked at?
So it means a growth on the lining of the colon. Some are nothing, and some are the type that will grow into colon cancer, and I'll go over that in a few more slides. How many people get colon cancer in America every year?
Too many.
Too many. All right, that's worth a shirt. All right. Thank you.
One is too many.
Right. That's a great point. Any other guesses? So about 150,000 people will be diagnosed with colon cancer this year and every year. And then 50+ thousand of them are going to die. And the thing that's most important for you to take away, other than get checked, is that every one of those deaths is preventable. Colon cancer is one of the most preventable cancer deaths, even though it's such a high, high frequency. And what we need to do is get better screening, get polyps out, and then we can really decrease that number. So with that goal that no one that is taken care of by Monadnock dies of colon cancer, we have a lot of work to do to get that number down. All right. So I've been here for 11 years, but I've been here full-time since March. And since that time, this slide's actually incorrect. Yesterday we found another one. So we found 11 colon cancers, essentially one a month since I started here. Okay? So every single month we found someone who needs to have surgery. Some of them need to go through chemotherapy. Some of them are going to pass away from their colon cancer. And we found one every single month here. And I'm doing about 200 procedures every month. So that's way too high. We really need to get that number down, and we need to really kind of accelerate our screening.
Is that people who have been coming on a regular basis?
Yeah, good question. So I would say they have not been people that have been coming on a regular basis. Usually when we find polyps, we then kind of look at how to get you back more often based on the number, the size, the pathology, your history. And then we bring you back on a more regular basis. We can actually dramatically decrease the chance that you're going to actually get colon cancer. The National Polyp Study was this huge study that was done where they show that if we take out polyps, we decrease cancer deaths. And I'll go over those numbers in a little bit, but there was a lot of people kind of fell away with COVID. The whole world kind of got delayed on doing testing. People are having a harder time accessing healthcare in the past few years, and the landscape of healthcare has really been dramatically changed in the past 5 years. And so people are getting backlogs. And what we're trying to do with my team is actually work through that backlog. My team has put a tremendous amount of work into saying, all right, who are we late on? Who are we, who's urgent? How do we get people in faster so that we can get caught up? That's a good question. All right, so a lot of problem is that people don't even acknowledge that they have a colon, right? They don't want to talk about it. They don't want to talk about the symptoms of it. But let's start with the colon. So the colon is this organ here. It's the very end of the GI tract. Okay, so things come in through the mouth. They go into the esophagus, stomach, then the small bowels, all this hiding in the middle. And then the liquid stool comes in here at the cecum and then travels around. And as it goes through the colon, it gets dried. So the whole idea of the colon is it's mainly there to really absorb salt and fluid and take liquid stool and make it into solid stool so that we don't get dehydrated by passing our waste. The challenge is that when all that stool sits in the colon for a long time, it gets concentrated and concentrated. Some of the bad things that are in there get concentrated and concentrated too. So we're increasing the exposure of the colon to some bad things. And a lot of it comes from a bad diet. Part of it, part of the reason that we get colon polyps is because we're aging. Part of it is other risk factors that I'll go over. But the American diet is kind of putting us at risk for this, to the point that previous screening was initially at age 50, but they started finding lots and lots of cancers in younger people. So now they want us to start looking at people at age 45. All right, so what are some of the symptoms of colon cancer? So the most important one that everyone needs to recognize is that the most common sign or symptom of early colon cancer is you feel 45 and amazing, okay? That's why we do this, because you can have colon cancer and have zero symptoms. And actually a lot of the 11 people that I found cancers in did not have symptoms. So that's a very important thing. And the worst thing is when someone comes in, they're like, oh, I didn't have symptoms, so why should I get checked? And then we find a big mass and they have to have surgery or go through chemotherapy. I'd say beyond that, the hardest thing is when someone says, geez, I had that hemorrhoid bleeding for the past 6 years. And we look at it and it's actually a giant mass in their colon that if we had gotten in there sooner, we could have taken out a polyp and they wouldn't have something terrible happening. But a lot of different symptoms can be colon cancer. So sometimes there's a change in your bowel habits, a lot of constipation, a lot of diarrhea. Sometimes it's bleeding. a lot of folks in this community are on some blood thinners. So sometimes the blood thinners make things bleed a little bit more. So they can get anemic, which means that their red cells are lower. So they could just get that fatigue from not having enough blood in their system. And then unexplained weight loss. The problem is that when you have symptoms, a lot of times that means that something is advanced. You know, the symptoms of a regular polyp, nothing. The symptoms of early colon cancer, nothing. But when you start getting symptoms, then you've moved along from early colon cancer to a more advanced lesion, and that means that it's going to be harder to take care of you.
How fast does it advance in terms of
Yeah.
nothing to something?
Yeah, that's a great question. So the kind of rule of thumb is that you go from normal colon tissue to colon cancer in about 8 to 10 years. And that's why if you think about generic screening, you know, you come in at 45, there's no history, no polyps. We put people on what we call the 10-year plan. They get to come back 10 years later if they don't have anything. But there are some things that'll make that happen faster. And so there are some people that have to be on a shorter interval even if they don't have anything because they're at greater risk. Was that a maybe question I saw back there? No? Just an insightful look. All right, so we were talking about how does it go from normal colon to colon cancer. So the colon is a tube, and it's got trillions of cells. If you took your colon and spread it out, it'd be like as big as a football field. And all those cells and lining are turning over all the time. You're constantly sloughing the lining of your colon, just like your skin. You know, you're constantly shedding. And when the colon is, you know, if this is the basement of the lining, you have the immature cells here, and they differentiate as it goes up to the lining of the colon, and then they slough off. And so you can imagine if you're making trillions of cells every so often, sometimes there's going to be an error or a mistake when they're making that cell. And when the cell is supposed to be turning into just normal colon lining, sometimes it has an error, and then it starts differentiating to something that's not as healthy, and it starts growing faster and faster. And with that, you know, we have little polyps that are, you know, sub-centimeter, and then they start getting a little bit bigger, and they start getting more of a blood supply, and then they get what's called dysplasia. Dysplasia means that it's going from polyp to I'm trying to turn into cancer. And then eventually it turns into, you know, a local cancer, which means that it's inside the colon, and then eventually it becomes invasive. And again, if you've got these, that's when you have, you know, these symptoms. My goal is to have everyone in the community get caught down here where we can find polyps and take them out, where we can prevent them from turning into cancer, or, you know, possibly in here where it's, you know, okay, you have something, it's too big for me to take out with this scope, glad we found it, let me send you to my colleagues in surgery so they could take it out, you know, and make it not turn into anything terrible like this.
Is that done here if you had to go to surgery?
Yes, ma'am.
Oh.
Brian, raise your hand. Dr. Quicken is our colleague. He runs our surgery department, and one of the really great things that Monadnock did when we came together, they said, you know, you guys have to work closely together. Let's co-locate your team. So we're in the same office, and we're just at different ends of the hallway, and their team's been incredible. I find something, and they just get them in and take care of them. And to put it in perspective, you know, without sharing any personal data, we found a cancer just earlier this week, and Dr. Quicken's taking them to the operating room tomorrow. That doesn't happen other places. You know, and that's what's one of the best things about our team, is that we could so efficiently take care of people and get them plugged in and taken care of. All right, so these are going to be some fun pictures from inside somebody's colon. All right, so, you know, this is up here, that's normal healthy tissue. It's supposed to look kind of like the inside of your cheek. This is a polyp, so this is an abnormal growth. It's, you know, it's probably along the lines of, you know, something like this. It's probably an adenomatous polyp, which is the kind that can turn into cancer. But what we need to do is prevent it from turning into something like this. This is getting to really the upper limits of what I could take out with this scope. And so that's something that I might say, you know what, I'm just going to take a biopsy from that and put a tattoo inside. and then say, Dr. Quicken, can you take this out surgically for us so that it doesn't turn into something? What we really want to avoid is this. So that's a picture of a real colon cancer. And that's someone that probably has symptoms, bleeding, change in bowels, anemia, things like that. And they're going to have a harder course to go through to get cured. So where's my IT? Oh, yes, ma'am.
If you come in 10 years, or if you have permission to come in 5 years.
Yeah.
But if you have symptoms like that and the 5 years or 10 years hasn't come up,
Yep.
you still need to try to.
You should always come see us. Yeah, so there's the screening, which is, hey, you're just on routine and you don't have any symptoms or anything like that. And then if somebody has symptoms, then we see them in the office to get them in sooner. So there are guidelines. So the guideline is that if someone has no personal history, no family history, no what we would say high risk background, when they hit 75, start having an individualized conversation. And that's hard, right? Because there are 90-year-olds that are running marathons and 60-year-olds that are not doing so well. And you always have to say, what's the risk benefit? Obviously, it's an invasive procedure. We use anesthesia. The bowel prep can be harder on some folks. But that said, if someone has, the chance, and again, it's hard to predict, but if it looks like someone has longevity, when do you start that? And then they start saying like around 80, do we do more of a cutoff? The challenge is though that's also for very low risk people. And a lot of people, as I was saying, half of people at 80 are going to have polyps. So as we age, we're much more likely to have them. And so you just have to say, individually, what do you want to do? Around that time, though, I started having conversations with them about if they wanted to move more towards like a non-invasive screening.
But
oh, of course. Sure.
We had a power interruption.
my computer spit out this afternoon.
Right. Now you have to find one
Yeah.
back in
Do you know what you see? You want your
there. Oh, yeah.
The question that follow up to what she just asked.
Yeah.
So if you have a history and you hit 75, is there not question that you would still be doing them every X amount of years that you were told?
Yeah, it's, there's guidelines and then there's the individual patient, right? And so I always say, come into the office, let's sit down, let's talk about what's going on and see, what's the best way to keep you safe. The last thing I would want is someone to die of colon cancer that we, didn't catch because they stopped screening. But you also don't want to hurt someone. You don't want them to have a complication from the procedure or from the anesthesia. And so I usually just say, let's come in and chat and see what options we have. A lot of times that's when we start talking about doing some of the non-invasive testing, like Cologuard and things I'll talk about in a little bit. And then if they're negative, we're good. And if they're positive, then we, reassess if you want to go through the procedure. Yeah, we'll talk.
When you say family history, how closely, or does that matter?
It does matter. So first degree relatives matter the most. Okay, so like a first degree relative with advanced polyps matters more than a grandparent with colon cancer, even though, that it seems like a more advanced lesion. But it also depends on how many people in the family have had colon pathology. Were they above 60 or under 60 when they first presented? Was it an advanced lesion that required surgery or had advanced pathology like villus pathology? We good? Oh, you're awesome, thanks. So it depends. And then there's things like Lynch syndrome that, are genetic clusters in families that make them much more likely to get cancer. So it kind of depends. And along those, I think in 2 slides, I've got a little bit more on that. All right, so colon cancer, right? I think about colon cancer in stages. So stage 1 is inside the colon, just in the lining. And then when you get into the 2s, you're going through the wall. 3, you've gone through the wall, you're in the lymph nodes. 4, it's spread things like the liver, or further distant mets. And the challenge is that your survival drops dramatically as you go stage to stage. So, for instance, stage 1, right? It's just on the inside. Dr. Quicken takes it out surgically. Don't need chemo. You don't have any lymph nodes. 92% survival. You get down to stage 4, like lots of liver mets and things like that. We're talking 11% survival and a lot of treatment to keep you alive. So it's tremendously important that we find things early and get them treated early. And obviously, as you get further down this, you're getting more and more symptoms as well. So one of the things to take away for that is if you have subtle symptoms, don't sit on them. If you have a subtle symptom, come get checked out so we can figure out if it's something up here as opposed to something further down that's going to be much more dangerous. So you guys were kind of asking about the guidelines, and the guidelines are always shifting and they're complicated. And as I said before, standard low risk was at 50, but now we've made standard low risk is at age 45. So there's kind of average risk, which means again you're not having symptoms, you don't have anything like long-standing UC or Crohn's disease, you don't have a family history of anything, and then over here we have some increased risk, and then on here is the much higher risk. So like people that have inflammatory bowel disease for greater than 10 years are at high risk. They get brought in like every 1 to 2 years. If you have a family history of polyps, a family history of colon cancer, then you should be seen earlier and be on like a 5-year schedule. So there's all kinds of things that we plug people into, and then we say, all right, how do we keep them safe and bring them back on the right schedule so that we can keep them out of trouble? The most important thing that I care about is that you get screened. How you get screened, I don't care. I obviously do colonoscopies every day, but colonoscopy may or may not be the right thing for every single person. And what matters is just finding that screening that keeps you safe and keeps you out of trouble. Because again, we just want everyone to get checked and not die of colon cancer. There's a lot of different ways that you can get screened. So colonoscopy, virtual colonoscopy, Cologuard, Shield. There's a lot, and I'm going to talk about each of them and let you kind of understand how they work, why they work, and what it means and how good they are. All right, so Guardant Shield is the least invasive. It's also the newest, so we'll talk about it first. So the nice thing about this is it's a blood test. Okay, so yeah, no colonoscopy, no bowel prep. It's just a blood test. You go to your doctor, they order it, and they send it off. But when you're thinking about screening and you're thinking about tests, you have to say, well, how effective is it, right? Because everything has some false positive, some false negative. That's the sensitivity that we're talking about. And the thing with colon cancer screening is all the tests have a sensitivity for colon cancer, but then they also have a sensitivity for polyps. And you want something that's good at catching cancer and catching polyps because the polyps are the thing that turn into the cancer. So this Guardant Shield, again, it's a blood test. So remember when I was telling you how your colon's always sloughing, it's always throwing off cells, and sometimes while it's reproducing those cells, it's turning into things that are bad like polyps and the cancer? Well, when those changes are happening, the cells that are going through those changes have some DNA damage. And sometimes that DNA damage can be picked up on a blood test. It's called circular DNA, and there's very specific patterns that they see in people that have colon cancer. And so this test is pretty good at picking up that circular DNA. And they say it's about 83% effective at finding early colon cancer. That means, though, that it's 17% bad at finding colon cancer, and that you could have a false negative. You could say, oh, my test is fine, and actually still have 17% of people can have a colon cancer still. It's good for that, but it's really bad for that. So it's only 13% effective at picking up colon polyps. So if you remember that whole spectrum from normal to polyps to bad polyps to cancer, it's 13% effective at catching the early polyps. And when we do colonoscopy, we take them out. That prevents them from turning into a colon cancer. But again, no bowel prep, no sedation. You just get a blood test. It's a relatively simple, easy thing to do. And then everyone's probably seen the commercials for Cologuard, right? So Cologuard is an at-home test, which is kind of nice. It's a stool test. So what you do is you send a stool sample back to the company at Cologuard. And what they're looking for is not the circular DNA that Shield looks at, but they're looking for DNA changes in the cells. So they're using a very specific software, and they're looking at the cells that are in your fecal stream that you send them. And they're looking for things that are the changes that are most likely to be happening as normal tissue is turning into advanced polyps and then into colon cancer. This one is pretty good. It's it's 92% sensitive for colon cancer, but again, they have a next gen one that's a little more advanced. That's 94% sensitive for cancer, but only 43% sensitive for the polyps. Now, whereas the Shield was 13% for polyps, this one's better. It's really good though for cancers. And you can see here, so high-grade dysplasia. Dysplasia is a term that we use in medicine, meaning like, man, is it just about to turn into cancer? And high-grade is the step essentially right before we would call it cancer. So it's 75% for finding that. And that's, again, you want to get that out before it turns into cancer. It's, again, 43% for polyps that are not dysplastic, but pretty good for finding the early cancers. As opposed to FIT testing. FIT testing is, that's the thing, when your doctor's checking, seeing if there's essentially, it's testing for blood in the stool essentially. And that one is a lot worse though. So, that's only 67% effective at finding cancer. So, you could have a negative FIT test and a third of people will still have a cancer, which is, that's hard.
I did this last year. How many years do you wait to repeat it?
Which one?
The Cologuard.
So, yeah, that's a great question. So Cologuard, they do every 3 years. Virtual colonoscopy, which I'll talk about in a bit, is every 5 years. Again, assuming negatives. FIT test is done every year because it's not as good. And sometimes cancers are bleeding on and off and bleeding off, so it can miss things.
Thank you.
So virtual colonoscopy. So some people can't have a regular colonoscopy. Sometimes their anatomy is odd and the scope won't go through. And again, sometimes people have concerns about going under sedation. So virtual colonoscopy is a model, again, to get people screened. It's kind of like a combination of a barium enema and a CAT scan. So it's in radiology and you're going through the CAT scanner. That's the donut with the table that slides through. Comparing it to regular colonoscopy, you still have a bowel prep. You have to clean out your colon so you don't get out of a bowel prep. They put you in the CT scanner after you drink some contrast that's used to coat the polyps. And then they have to put a hose where you wouldn't want a hose because they have to fill you with carbon dioxide so that they can see. But then they get these amazing, this is kind of what they see. They almost get to do like a fly through the colon. They're looking in this tube of the colon while they're sitting at their radiology viewing station, and they'll say, hey, there's a polyp there, and then obviously they reach out to us. It's good for things that are about 10 millimeters or more. So CT scan, it's taking slices. It's like when you're at the deli and you're getting the lunch meat sliced up. It's doing that through your body, and so there's a space in between each slice. Polyps can kind of hide in the spaces where the slice isn't. And so it's really decent for polyps it's 90% for polyps greater than 10 millimeters. But there's a lot of things that are smaller than that could hide and give you a false negative. It's also not great for flat things. We're seeing a lot of what's called sessile serrated adenomas. There are these flat polyps that can kind of hide. They look more like a carpet than kind of like this, which is looks like a mushroom. And it's not as good for the flat ones. If you have a positive Shield, if you have a positive Cologuard, if you have a positive CT virtual colonoscopy, they're always going to refer you for a regular colonoscopy. It's not something that you would just sit on. If you have one of these come up positive, you would need to then get checked out. And I'd say, 2 or 3 a week are people that have had positive Cologuards that are coming in.
So if you get a negative, you could wait 3 years to get retested.
If
and
you have-
could still be positive if it's not
Yep.
catching it.
Yep, I mean, everything has, how many do we catch and how many do we miss? I mean, even regular colonoscopy has a miss rate because things can hide in the nooks and crannies. Yeah.
So are the cesspool polyps
I'm
is, dangerous and regular?
Say again, I'm sorry.
Are the cesspool, the flat polyps, the same?
Yeah, so a sessile serrated polyp, we treat just like an adenoma. And then they look for dysplasia as well. All right, so who's had a colonoscopy? Excellent, me too, I've had 3. I have a family history, so I'm on the frequent flyer plan. So colonoscopy, it's a thin camera, it's about as thick as your finger, okay? And we put the camera in, we drive through, and then you can see it's got ports on it. So I put air into the colon. It has a suction. It has power washing, so we can really clean it up and get a good look in there. And then there's a port for instruments. And what you can see, so this is a snare. Snare is like a metal lasso. And when I find a polyp like this, my team helps me put the metal snare through, and we cut it off, suck it out, and send it right off to pathology. Yep. And then we can say, all right, that polyp's not there anymore, which is good. And then we send it off to pathology and they say, all right, is it hyperplastic? Is it adenomatous? Is it a sessile serrated adenoma? Does it have dysplasia? Those almost turning into cancers, or does it have cancer in it? As a polyp gets bigger, if you recall from that other side, it has more and more chance of having cancer. So you get like greater than a centimeter, it increases your risk. You get into 3 to 5 centimeters as a greater risk of having cancer cells inside it. So far, regular colonoscopy is the gold standard. Everything else is decent, but nothing comes close to our numbers. We essentially catch 90% of the polyps that are in there, and it's probably closer to 93, 94 for polyps that are greater than a centimeter, which is starting to get a little bit more advanced.
What about you said that the risks with this as people get older?
Yeah.
So what are those risks so you wouldn't want to do one of these?
In 2 slides, I'm going to tell you.
Okay, thank you.
The most important thing to take away is this, that doing colonoscopy reduces your chance of dying of colon cancer by almost 70%. And that's a tremendous number. There's no other screening of anything that reduces your risk of dying of something by that much, by almost 70%.
So, given that, the insurance companies,
Yeah.
they're usually pretty good about approving a colonoscopy versus wanting you to go through one of the lesser invasive ones?
Yep.
Or how does that work? Is it?
So there have been changes. Laws and insurance companies are funny. There was a period where insurance companies, so during Obamacare, they said you have to cover screening. That was a really good part of that law. One of the challenges was insurance companies said, oh, great, so if we pay for the Cologuard, that counts, right? And the Cologuard is cheaper than a real colonoscopy. So then they were dinging people. They're like, well, now it's on you, right? The Cologuard's positive. Now it goes from screening to diagnostic, and so people had to pay out from their deductible. There was a change to the law to fix that if something is found on a screening, then you still have to cover the screening. The law had to catch up a little bit to the insurance companies. All right, your question. So the risk, right? So 1 in 3 are going to have a polyp at age 45. 1 in 20 are going to get colon cancer in their lifetime. So you have to say, all right, like, what are the risks of not doing it versus what are the risks of having the procedure? So, and then when you talk about risk, you also have to say, like, what's real and what's kind of like the fear factor, right? So I just look at the numbers. So 1 in 2,500 people are going to die of choking, okay? 1 in 100 are going to die in a car accident. That's a big number. Actually, 1 in 20 are going to die falling down. And if you think about it, 1 in 20 are also going to get colon cancer. So like, they're big numbers. The risks of colonoscopy are about 0.5% to 1%. Now, here's the risks. You get sedation for the procedure. Anytime you get sedation, it can affect your blood pressure, your heart, your lungs. There's a little bit of stress on those systems. So people that have, bad heart, bad lungs, they're at increased risk of complications from anesthesia. Sometimes people have aspirations, things like that. And then the risk of the procedure itself. Putting a scope into your backside is actually completely unnatural. And so sometimes the scope can cause a little bit of damage. Sometimes there's weaknesses in the colon wall that can, the colon wall is actually millimeters thick. One of the scariest things for any GI doc is doing a colonoscopy in the operating room with one of their surgical colleagues and seeing that you can actually see the scope through the colon when, it's very, very thin. It's tough material, but there's a small chance it perforates, especially if we're taking out a bigger polyp. You can imagine when you're lassoing something, if you have to lasso something that's got roots, that can always, there's a small risk that you can cause a perforation. So that the textbook risk is about 1 in 1,000. I'm lucky my number's better than that. I think part of it's the fact that I've stopped counting after about 35,000 procedures. When you do a lot, you just kind of know when the scope's going to misbehave or not. It's not zero. But again, I've got a very close relationship with my surgical colleagues, and if we have a perforation, we find it quickly, we get folks in and repair it very quickly and take care of them. But if you think about a 1 in 1,000 risk of something bad happening versus a 1 in 19 risk of getting colon cancer and not getting it taken care of. There's also a chance of bleeding that happens about 1 in 3,000. I was happy, we do a lot of quality data to make sure we're doing a good job here. And we did 2,500 cases in the past year, and we haven't had a single bleed. And I think one of the reasons is because we use these hemoclips. So a hemoclip is like a little metal staple. And so when I take out a polyp, if it leaves a defect where I take it off, we'll put these metal clips on to pinch it and close the defect and help decrease the risk of bleeding. Our community has some older folks that have blood thinners and things like that. And blood thinners, if you're on a blood thinner and you nick yourself shaving, you bleed more, or you bang yourself on, the shin, you bruise more. Well, it makes it more likely that you're going to bleed if I take something out. So I've been a little bit more aggressive putting clips on sites to help decrease the bleeding risk. And it seems like it's been an effective modality because we haven't had a single, what we would call a post-polypectomy bleed in the past year. I mean, I'll probably have one tomorrow because I said that, but
Are they temporary or do they dissolve?
they do not dissolve, but the vast majority fall off over time because as that tissue is sloughing, over time they will fall off. But they stay on for a couple weeks.
So they get expedited out.
Yes, and I don't want them back. Okay, thank you. I was talking about quality data. So my team tracks a lot of things. We track, how are we doing with our bowel prep? How are we doing with our completion rate? Do I get all the way to the cecum? There's something called a withdrawal time. So you can imagine if you put the scope in and just pull it out real quickly, you're going to miss things. But if you take your time and spend 8 to 10 minutes looking around, you're more likely to find polyps. There's something called an adenoma detection rate. So adenomas are the type of polyps that turn into colon cancer. We track actually how many polyps we find, and we track how many cancers we find because we want to make sure that we're hitting all the standards. And we work with the New Hampshire Colorectal Cancer Registry. It's out of Dartmouth. And what they do is they have a gigantic database of all the colonoscopies in the state in the teams that are participating. I've been participating with them ever since I've been in the state, and it's been 17 years now. But we set up Monadnock when I got here. We set it up as like an individual site. So we track all this, and every year we get reports to let us know, are we doing a good job? Are we catching enough polyps? Are we not missing things? And the really cool thing is that they have so much data. They've got tens of thousands of procedures and pathology reports that now they're able to, like, they helped move it from 50 to 45 because they realized that we were finding so many earlier cancers. And so it's a great quality data, and we use it to make sure that we're doing a good job.
And why do you see that drop from 50 to 45?
I think mostly because we're eating things that are really not good for us. And food has kind of turned into a science experiment, and it causes damage to the lining of the colon. They're seeing a lot of cancers increase, but this is obviously one of the ones that we needed to change our guidelines on. Yes, ma'am?
Is there any risk with the virtual colonoscopy?
Sure. So it's a little bit of radiation, but less than flying cross country. But they are insufflating, and so anytime you insufflate, put air in, there's a small risk of perforation. The virtual does use like a pressure sensor, so they're always trying to get enough in so they can see, but not too much that you pop. The thing about it is, there's no risk of sedation because there's no sedation. You have to be awake because they make you move around to get the contrast to shift and everything like that. It's kind of audience participation.
As far as detection, is it as good as a regular colonoscopy?
It's as good. So it's low 90% on polyps greater than a centimeter or 10 millimeters, but not as good on flat ones. So I'd say, if I was ranking them best to worst, I'd say the best one is regular colonoscopy, and the next best is the virtual, and then I would say the Cologuard, and then the Shield, and then the FIT test.
Thank you.
Yeah.
Is the one she just asked about, is that as painful as the sigmoid? That was horrible.
Which one? The virtual?
The sigmoid was horrible.
Yeah. So a sigmoid is just half a
I know
colonoscopy.
it was painful as all get out.
Yeah. And that's why we use the propofol here, to make folks as comfortable as possible. We have an anesthesia team here that's incredible, that makes folks really comfortable.
Yeah, they were great.
Yeah, they're incredible. We have a great team. Yeah, it's like warm blankets and a great nap.
It's perfect.
So I have a goal, right? No one that we serve dies of colon cancer. It's this team that's doing it. We have an incredible team, and we're working very hard to help that achieve that goal. So I appreciate you guys coming out and talking to us. All I care about is get screened, and if there's ever anything we can do to help you with that, please let us know. And if there's any other questions.
Could you talk a little bit about the diet? Because you said that's a big emphasis for causing
Yeah.
more of the problem.
Yep. So ideally, don't eat anything that you didn't make at home, and don't eat anything that comes in a box. They really say more and more, like anything in the middle of the supermarket that's processed or ultra processed is essentially a science experiment. So what they want us to eat is a very lean Mediterranean type diet. So lots of fruits and vegetables, lots of healthy fats, and lean meat and fish. And try to stay away from the stuff that's processed.
What about the small intestine? You're only looking at the large intestine, right?
Mhm.
Do you ever is cancer not common in the small bowel?
They are less common, but they can occur.
And how
But-
would you find those? Was that an endoscopy?
Yeah, so there's a couple ways to find that. Sometimes you find them on things like a CAT scan. But let me jump back, sorry. Okay, so, esophagus, stomach, and then small bowel is the 17 feet here in the middle before the colon. They're much less common compared to colon cancer, but they can occur. Things like you can get adenomas, so polyps that turn into adenocarcinoma. You can get things like GIST, which is a stromal tumor that can turn into, it's a cancer. We have a really cool test that we do here called small bowel capsule enteroscopy. So it's about this big. It's like the size of a big vitamin, and it's a video camera. You swallow it, and it takes it takes an 8-hour movie, and then we get popcorn and watch it on.
That shows a large bowel too. That shows everything,
So the small bowel capsule has about an 8-hour video, and it's mostly for looking at the small bowel. The same company made a colon camera as well that didn't work out as well because, the small bowel is a straight tube essentially, whereas the colon is, lots of twists and turns and folds and pockets. So, but yeah, there are ways for us to look in the small bowel also.
Thank you.
Sure.
So I just want to ask, because when I saw you, I know you don't remember me, I was facing the other way, but.
Could you turn around? Teasing.
You talked about there's a whole menu of prep.
Yes.
I hate the prep.
Yes.
I don't know if anybody here likes it, but I never got that menu. Where do I get that menu?
So if anyone wants a different prep, they just have to ask our office.
Oh, okay.
Yeah. So the way the preps are, we want something that keeps you safe,
Yeah.
right? And then we want something that cleans you out, and then we want something that makes it so you won't give us a bad review, right? So I get that. The prep is not fun.
It's probably better than cancer, but.
Yeah, and it's hard because so way back when I started training, there was something called Fleets. Everyone loved Fleets. It was the best. Small volume, tasted great, worked amazingly, but it shut down a bunch of kidneys. And then the people with the kidneys got angry. So then they changed it. And then we used the Go Lightly, and that's the stuff that everyone hates. It tastes, like vomit. It's horrible. And most people actually do vomit because it tastes so badly. So then we started using what's called Miralax. Miralax is the same chemical that's in the Go Lightly, but you put it in something that tastes better. But we always have to use a decent volume. Like even, there's something called a pill prep. So you could take a whole bunch of like salt tablets, but you have to drink the volume still because the volume is what flushes and the volume is what protects your kidneys. But there are some smaller volume ones. There's soup prep. There are things out there. Most insurance companies like to make the more palatable preps as expensive as they can. So, whereas the Miralax probably costs $40 all in, you could drop $150 on, a tier 3 prep that they don't want to pay for. But we're always happy to explore other options. Just call the office and we'd be happy to set something different up.
Thank you.
Sure. Yes, ma'am.
Yeah, just a question on, you were saying the insurance company's changing
Mhm.
policy. So if they tell you you can't do 10 years, you have to do every 5 years?
Yep.
But you still have to stay on top of that to see if they take that away from us?
So all of the agencies that kind of look at endoscopy are lobbying to keep the insurance companies under control. But if there's different what we call screening codes. So there's like you have nothing wrong with you screening code. There's you've had polyps before screening code. You have cancer. So and if you use the right screening code, which our team's really good at that, they should cover it as a screening. Sure. Yes.
I got one. So, say if you do have a cancerous polyp, and I think it's the snare tool that you use
Mhm.
to cut it out, is there any risk of, like, on a cellular level, like those cancer cells spilling out into your colon?
Great question. So whenever we take something out, either endoscopically or surgically, we're always talking about margins. And so there is absolutely a theoretical chance that if you took a polyp out and didn't get anything, that there would be some left over. The snare is pretty good because the lasso kind of draws in tissue. So a lot of times we get the polyp and then a little margin of healthy tissue around it. But that's always one of the things that we're looking at. If I take out something, they're like, oh, there's cancer in the polyp. Then they say, how far is that cancer from where you cut it? Is it far enough? Does it exceed up to it? A lot of polyps look garden variety when they're in there. But if there's something I'm like, ooh, that looks abnormal, I think that's going to be a problem, I'll tattoo it so that it's easy to find the site later, even with the polyp gone. And sometimes we say, I got to go back in 6 months just to make sure nothing's grown back there. And then sometimes, You know, sometimes they've got roots and sometimes it grows back and I go back and I take out more and then sometimes I say, Brian, it's your turn. You know, take out the whole tissue.
Do you try to take out the whole polyp if it's small enough that you can do that rather than extract a piece and then things could spread?
Yeah, absolutely. So you always try and take it out in one piece at one time. Some of them are big enough that I have to take them out piecemeal. So I have to take out some, take out some, take out some. They're the ones that you usually go back in a year to look at to make sure nothing's grown back. Yeah. Anyone else? So I lied a little bit about t-shirts only for people that answer questions. We actually have a t-shirt for everyone. But thank you.
Well, you didn't lie, you just said I'm going
I just forgot to, yeah. I was encouraging.
Thank you, Dr. Gilbert.
Thank you.